Okay, we're back with our fourth and final lecture where we're going to be talking about guidelines for a tiny baby program. So we've already had the first lecture on basic terminology for the ventilator. The second lecture was me and Rose doing the Draeger for conventional ventilation. The third lecture was looking at high frequency ventilation. And so now we're going to move on to look at our brand new respiratory guidelines. These guidelines were designed looking at what other units are doing across the country, and we're trying to make them to fit our own unit. This is a project that is going to have many changes over the next couple of months as we gather data. So we'll be asking you to help us with these guidelines and to figure out what is going to work best for our unit. Why should we even do a protocol for ventilation? Well, evidence shows that early extubation of premature babies lowers the risk of BPD and lowers related morbidities such as neurodevelopmental impairment and death. So we also know that the ability of clinicians to accurately predict successful extubation is limited. Extubation failure has been associated with significant morbidities and mortality. The process of extubation is complex, requiring careful planning. And we're looking at three major steps in this whole planning issue. 1, weaning of the ventilator. 2, assessment of extubation readiness. And 3, provision of post-extubation support. So there needs to be a way to identify good objective criteria for predicting successful extubation and to reduce the duration of mechanical ventilation as well as the incidence of failed extubation. The method for weaning from the ventilator and proceeding towards extubation has been variable and inconsistent across neonatal units. We know this is true in our own unit. Each provider has their own way of weaning the ventilator and their own way of getting the baby extubated. Peri-extubation practices can vary considerably, and decisions are frequently physician-dependent and not really evidence-based. Failed extubation for these extremely low birth weight infants range from 40 to 72% in most studies. And what we do know is that the clinical literature clearly supports that both prolonged ventilation and premature unsuccessful extubation, followed by reintubation, are associated with poor outcomes. So our goal here is to have a protocol or guidelines, actually, in ventilation management on these extremely low birth weight patients, a way to have a guideline for extubation, and then a way to have reintubation guidelines as well if it's necessary. So here's a list of the papers that I used to come up with these guidelines. These are available to you if you'd like them. So let's look over the guidelines as they stand right now. Just remember that these guidelines are subject to change over the next couple of months as we do this for more and more of our extremely low birth weight babies, and as we get more information from you and more data that we collect ourselves. So looking at the guidelines, in the delivery room, if the baby is less than 25 and 6/7 weeks, they're going to get intubated and we're going to give them surfactant in the delivery room. If they're greater than 26 weeks, we're going to attempt CPAP only. This is because studies have shown that surfactant is not always needed in these extremely low birth weight babies, and that frequently we can just get by with CPAP. It also has been shown that babies who have just CPAP, it lowers length of stay and lowers the incidence of BPD. If the baby is greater than 26 weeks and requires intubation, we're going to give surfactant within an hour of intubation. In the NICU, for less than 26 weeks gestation, we're going to start the babies on the jet, and we're going to talk about the reasoning behind that in a minute. We're going to start the baby at a rate of 360 or even less to prevent air trapping. We'll talk about that in a second. We're going to keep the PaCO2 at 40 to 60, and notice when there's an A next to that PaCO2, that is talking about arterial blood gases. We're going to wean the oxygen until less than 50%. And then we are going to decrease our main airway pressure by decreasing the PEEP and the PIP as able. We talked about all those terms in our first lecture. Our minimum PEEP is going to be between 4 and 6 centimeters of water, and with oxygen requirements of less than 40%. We're going to look at lung inflation on our chest x-rays. For these small babies, we're going to consider extubation directly from the jet to either CPAP or CPAP after meeting the extubation criteria, which we're going to outline below. If we need to use the Draeger or conventional ventilator, we're going to use assist control volume guarantee mode, and we've already discussed those in our Draeger lecture. In the NICU, if the baby is greater than 26 weeks of gestation, if the baby is intubated within 48 hours of delivery, we'll give surfactant after confirmation of the ET2 by X-ray. If the baby gets intubated, we're going to start with our volume guarantee mode, and then we're going to extubate directly to CPAP or CPAP when meeting these extubation criteria. So these are the criteria of who gets intubated in the delivery room, who gets intubated in the NICU, who gets surfactant, when they get surfactant, and how we're going to try and manage these babies. They're broken into two groups, less than 26 weeks and greater than 26 weeks. So why are we going to use the jet in these less than 26 weekers, these extremely premature infants? So for babies less than 27 weeks gestation or less than 1,000 grams, the primary goal of this approach is to minimize mechanical injury from air trapping and or hyperinflation. So what is air trapping? So air trapping is when you have pulmonary hyperinflation, the lung is overinflated, the end expiratory pressure, the PEEP, inside the alveoli, the actual total PEEP, is higher than the PEEP that you are applying by the ventilator. In other words, if I put in a PEEP of 5, the actual total PEEP is maybe 6 or 7, and that's because the lungs are hyperinflated. So the difference between this PEEP, this total PEEP, and the actual PEEP that we're supplying by the ventilator corresponds with this intrinsic PEEP, which is also known as auto PEEP. In other words, auto PEEP is when there's air trapping, breath stacking, hyperinflation, inadvertent PEEP, occult PEEP. These are all the same things, meaning that we are overextending the lung and we can cause barotrauma. This is when you see issues with PIE and pneumothoraces. So what we're trying to do is we're trying to prevent air trapping by using the jet early on these small babies. The reason that we're using lower rates in these small babies is that it can prevent this air trapping or hyperinflation. So babies who come into the unit who are less than 26 weeks may get started on a low rate of 360. If we see that there's some PIE or air trapping, we might drop the rate to 300. And if as the baby's lungs change and as the baby needs higher CO2 removal, we will increase the rate as required. So this is where we discuss extubation criteria. Just remember that these small babies, this guideline is for the first 10 to 14 days of age. So here's the criteria that we're going to be looking at to extubate the baby. The baby needs to have a PaCO2 of less than 50. Remember that PA means that it's an arterial blood gas. pH has to be above 7.3. Capillary blood gases, the PCO2 should be less than 55. We need to be in less than 40% oxygen with a SAT of greater than 88%. The mean airway pressure, and we talked about this in our first lecture, has to be less than 10, and that can be read right off of the ventilator. For the jet, the amplitude, also known as a delta P, we discussed that in lecture 1, should be less than twice the mean airway pressure. Babies should have been checked for a PDA, or at least be hemodynamically stable without evidence of clinical duct. The skin integrity needs to be able to support a CPAP device. The size of the nare, size of the infant needs to be able to support the CPAP device. The care team, the bedside nurse, the provider, the MD, NP, and respiratory therapist are all available to discuss extubation, mode of respiratory support, post-extubation. We would like to try and get extubations done earlier in the day, before 4 p.m. No later than 3 p.m. is ideal. The MDNP needs to be available and at the bedside for extubation. We're going to be looking at this as if it's a procedure and as the baby transitions off of the ventilator. We're discussing and we're going to be trying this extubation readiness spontaneous breathing challenge. We're either going to decrease the rate on the conventional vent or we're going to try some ET-CPAP for just a couple minutes to see if the baby can tolerate it. If the baby has a significant bradycardia or has oxygen desaturation while undergoing this ET-CPAP, we're going to consider whether the baby is ready for extubation or not. So what happens after extubation? When does the baby meet criteria for reintubation? If the baby gets extubated and has a requirement greater than 50% to maintain the SATs greater than 88%, or greater than 50% and unable to wean over 2 hours, we should reconsider and we should think about reintubating. If the PaCO2 is greater than 60, or if the capillary blood gas CO2 is greater than 65, consider reintubation. If the baby becomes hemodynamically unstable, has a low blood pressure, poor perfusion, we need volume or pressure support of greater than 4 hours, we should consider reintubation. We will be filling out an extubation tracker with each of these extubations and each reintubation. This is the data that we'll be collecting to see if our guidelines are working or if they need to be tweaked a little bit. So this is the extubation tracker that we will be using. You won't be filling them out. We will be keeping them in the chart room, and then we will be looking at them after 10 patients, after 15 patients, after 20 patients. We're just going to be taking some notes on what worked for this baby or what didn't work. So these guidelines are pretty simple. We're going to start using them by the end of May, maybe June 1st, and we'll start keeping track of which babies these guidelines work for and what we need to work on to get maybe some change in the guidelines. In order to do that, we're going to need some input from you, and we're going to need some input from us as well. So look for these guidelines to be coming out soon, and we will be changing them over the next few months.